Welcome everyone to the Leukemia and Lymphoma Society of Canada's training called Acute Myeloid Leukemia, Review for Oncology Nurses. This training is geared towards the healthcare professionals in our community. Today with Cindy Murray and Shannon Nixon, both nurses at Princess Margaret Cancer Centre, we'll talk about the nurse management of acute myeloid leukemia. First, let me introduce myself. My name is Natasha Sani and I'm the Community Engagement Lead from the BC region. Before we begin our main presentation, I'd like to share with you our mission and highlight some resources that might be helpful for you and your patients. At the LLSC, our mission is to cure blood cancers and improve the quality of life for those touched by blood cancer and their families. Ultimately, we're here to serve the community. We offer guidance and support to people affected by blood cancer every step of the way. We offer you a continuing education program that you can join freely. Last year, we sent a survey to hematology oncology healthcare professionals around the country. A need for training on blood cancers has clearly been identified. You can register to one or more of our trainings that you can do at your own pace and receive an electronic proof of participation. We also offer a variety of educational resources and services for those affected by blood cancers, as well as for healthcare professionals. In addition to disease information booklets, fact sheets, and videos, we also offer other valuable services such as our First Connection peer support program, virtual support groups across the country, a multitude of webcasts, podcasts, and COVID-19 resource center, as well as access to personalized support from our community services managers in every region. We invite you and those affected by blood cancers to visit bloodcancers.ca for more information. All of our materials can be downloaded or ordered through our website. The process is very simple. With this handy electronic form, you can order materials to be shipped to your location in just a few clicks. If you have any questions, please reach out to the community service leader in your region. We're always happy to help. I would also like to showcase one of our precious tools to help the blood cancer community manage their health. This is called the Health Manager app. This tool is free to download and is available in French and English. You can find trackers on side effects, medication, food, reminders, meal planners, etc., all within the app. You can download it on Apple or Android devices. Emotional and practical support is important for the LLSC. Our peer support program has been identified as a key service, but many don't know about it. Volunteer survivors who are at least 1 year out of treatment are selected and trained and share their stories with those newly diagnosed patients or those facing a new treatment option. Age, gender, diagnosis, and treatment are all considered to ensure the best possible match. This program helps to build hope, alleviate anxiety, and create realistic expectations. We also offer a virtual support group, which are offered coast to coast and are professionally facilitated. Our group support gives the opportunity to the blood cancer community to connect with others who are facing the same challenges from the comfort of their own home. Each participant builds connection through group discussions, sharing coping methods and information, as well as breaking isolation. Visit our website, www.bloodcancers.ca, for more information. It is now time to introduce you to our speakers, Cindy Murray and Shannon Nixon. Cindy Murray is a nurse practitioner in the Complex Malignant Hematology program at Princess Margaret Cancer Centre. She has more than 40 years experience working with patients with acute leukemia and other complex hematological malignancies. Shannon Nixon is a nurse practitioner in complex malignant hematology at Princess Margaret Cancer Centre. She has over 20 years experience working with patients with acute leukemia and other complex hematologic malignancies. Over to you, Cindy and Shannon.
Okay, thank you very much for that kind introduction. These are the topics that we hope to cover within the next 45 minutes to an hour. In order to understand acute myeloid leukemia, or AML, it is helpful to review the normal development of blood cells, which is a process known as hematopoiesis. This takes place in the bone marrow, which is the blood cell forming organ of the body, and it results in the production of three main types of blood cells. The red blood cells that carry hemoglobin and oxygen to all the organs in our body, the platelets, which are responsible for helping our blood to clot, and the white blood cells that are essentially our immune system. Blood cells start with the hematopoietic stem cell that you can see at the top of this diagram. And this cell has the capacity to replicate and differentiate. Early on in the differentiation process, a cell commits to the myeloid cell line or the lymphoid cell line. And from here goes through a number of differentiation steps to become the normal blood cells. This is a very simplified version of hematopoiesis. Once these cells are mature, they're released into the circulation to do their jobs throughout the body. These cells have a limited lifespan of a few days for platelets and white blood cells to a few months for red blood cells. So the bone marrow is constantly making new blood cells to replace the dying ones. AML is a cancer of the bone marrow and is the result of acquired changes in the DNA of the developing stem cells. These changes can be evidenced by chromosomal abnormalities and/or gene mutations, and are a very important piece of determining prognosis and treatment recommendations. What happens is the cell that becomes transformed because of this genetic mutation starts proliferating. These cells are known as blast cells. They're immature cells. They can't function the way that they should be functioning. They proliferate, and this is known as clonal expansion. They can accumulate in the bone marrow, and then they're released into the circulation and can infiltrate other tissues. What happens with this overproliferation of immature cells is that it leads to the inhibition of normal hematopoiesis, resulting in decreased numbers of red blood cells, white blood cells, and platelets, conditions known as anemia, neutropenia, and thrombocytopenia. On this slide is a more detailed version of hematopoiesis affecting the myeloid cell lines. And as you can see, there's a number of different steps or differentiation steps that the cell goes through. And the transformation or the genetic mutation can happen at any one of these steps. AML is a relatively rare disease, as you can see on this incident mortality chart. This is a few years old from 2016 and 2017. So as you can see, AML occurred in about 1,000 people in those 2 years. But out of all of the leukemias, it is the most common acute leukemia affecting adults. In the pediatric population, it's ALL that is most common. It has a fairly high mortality rate, as you can also see, which is outlined in the orange bars on this graph. So we know that the reasons people develop AML are because of genetic changes, but why do these genetic changes happen in the stem cells? It can be the result of exposure to chemicals such as benzene, chemotherapy agents, radiation, smoking. It can be a result of previous blood cancers. For example, myelodysplasia can transform into AML. Some genetic disorders, such as Down syndrome and Fanconi anemia, can progress to become acute myeloid leukemia. And once upon a time, we didn't think that there was any inherited predisposition to AML, but we're learning that there probably is. AML affects men more commonly than women, And it's a disease of aging. So the median age at diagnosis is anywhere from 68 to 71 years, depending on the database that you are looking at. And more than 50% of patients diagnosed with AML are over the age of 65. The clinical manifestations of AML are really related to the reduction in the normal blood cells. So because of reductions in the red blood cells, patients have low hemoglobin, which manifests as fatigue, shortness of breath, lightheadedness and dizziness. They may look really pale. Because of the low platelet count, patients may have easy bleeding and bruising. Because of the low white blood cell count, and in particular, the neutropenia subclass of white blood cell, patients that are at a high risk of infection and fevers.
Other clinical manifestations are the result of leukemia blast cells infiltrating other tissues, such as the gums, resulting in gingival hyperplasia. These cells can infiltrate the skin, resulting in skin lesions. They also might penetrate the central nervous system, leading to CNS symptoms. Patients may be experiencing bony pain, myalgias, and arthralgias because the bone marrow is overly active. And although most patients present with a low white blood cell count at diagnosis, some present with a high white blood cell count. And this can pose the problem of leukostasis, where there's a blockage or plugging of the microvasculature, leading to decreased tissue perfusion. The presence and severity of these clinical manifestations vary greatly from patient to patient, but usually the presenting symptom is related to one of the cytopenias. These symptoms takes the patient to their primary healthcare provider or the emergency department. Blood work is done that reveals the cytopenias and oftentimes leukemic blasts in the peripheral blood, and a referral is made or should be made to a leukemia center within 24 to 48 hours, and a diagnostic workup is done.
So as we just reviewed, uncontrolled blast proliferation can lead to these consequences of severe anemia and bleeding, infections. So historically, AML was considered a very aggressive and progressive disease. But what we've learned over the last 10 to 15 years is that this rate of proliferation really varies amongst patients. So even 5-6 years ago, we used to immediately admit a patient to hospital if they had a suspected or a confirmed diagnosis of AML, to begin chemotherapy as soon as possible. But in the last 5 years, we haven't been doing that because we will discuss in the next few slides why. So of course, there are some patients who will present clinically unstable, but not all of them. So not all of them need to be admitted immediately. So once they arrive at the leukemia referral center, we do a very extensive workup for the diagnosis. And the two main goals of this workup are to characterize the disease and also to assess the patient's ability to tolerate treatment. So we do a lot of blood work that involves a complete blood count. We can look back, hopefully, at some previous results for provincial health record to see what the rate of progression based on what the blood counts are telling us. We do coagulation studies because some subtypes of AML are associated with a lot of coagulopathies. We send peripheral blood off to be examined by the hematopathologist and for special studies, which we'll talk about later, because there's these blasts in the peripheral blood often. We also screen the patient for latent infections like hepatitis, because that can impact the complications of treatment. We do a very careful review of systems on the patient and a physical examination because we really want to understand how fit the patient is, We want to look at their comorbidities, their fitness level. We want to know a bit about their social history as well. Do they have caregivers that are going to be able to participate in their care after treatment is started? We also ask patients about their private insurance availability, as some of the drugs that we're using these days are not covered by provincial insurance plans. We ask them about their family history. We want to see if there's a lot of cancers in their family that could be connected to genetic mutations that are also seen in acute leukemia. We do an ECG, we do some CAT scans because we just want to get a sense of what their organ functioning is. One of the big tests that we do that's very important is the bone marrow aspirate biopsy, which we'll go into a little more detail in the next few slides. We also do typing, tissue typing on these patients to determine their HLA typing in case allogeneic stem cell transplant is going to be part of their treatment recommendations. And Shannon will talk about this a bit later. Also, depending on the age of the patient, we may refer them to some of our specialty programs like the adolescent and young adult program for patients under the age of 39, where a big focus is on fertility issues. Or for patients who are elderly, we have the older adults with cancer assessment clinic where they can do a more detailed assessment of the older patient population. And again, just to reiterate, one of the really important pieces of seeing these patients and working them up is to triage them to determine whether they need to be admitted to hospital immediately. As I said, some patients are quite ill when we see them and others are not. The bone marrow aspirate and biopsy is the gold standard test for diagnosing AML. And you can see on this slide what that involves. We want to get an actual sample of the bone marrow since it's the blood forming organ and is where this disease starts. A patient has to have 20% or more of leukemic blasts in the bone marrow sample to have their disease categorized as AML. Or, as we'll talk about in a few more slides, they have to have cytogenetic or genetic abnormalities that define AML, plus at least 10% blasts in their bone marrow. So historically, we've always said that patients had to have 20% blasts in their bone marrow. Now we're saying if they have certain cytogenetic and genetic abnormalities, but less than 20%, they will still be determined to have AML. I think another important feature is that if the peripheral blood has more than 20% leukemic blasts in it, we can call the patient as having a diagnosis of AML. So the purpose of doing the bone marrow aspirate and biopsy is really to characterize the disease. I like to think of it as the testing being done sort of in two broad categories. One is to determine the stage of differentiation at which that leukemic insult happened back in the differentiation process. I don't think I explained it really well, but because the genetic mutation can affect any stage of differentiation, there are many different subtypes of AML, so it's really important to figure out where that happened. And the second category that we really want to look at is looking for those genetic changes that started this whole process. Because as we've learned, cytogenetics is the most important factor affecting prognosis of patients. So we really need to have that information these days to establish prognosis and guide treatment. So we use a number of different tests. So to determine the stage of differentiation, we use morphology, which is essentially sending off a sample of those blast cells for the pathologist to look at under the microscope using different staining techniques. We also send the sample off for flow cytometry and immunohistochemistry. so that they can look for certain antigens that are on the cell surface or inside the cell that would help distinguish at which stage of differentiation the insult happened. We send the sample off for cytogenetic techniques, which is known as karyotyping, looking for abnormalities in the chromosomes. And we look for specific gene mutations, sometimes using a technique called PCR. And as I said, this is all necessary to help us determine prognosis for the patient, how they're going to respond to treatment, and to guide the treatment decision. AML can be classified in many ways. So it can be classified just based on the morphological features of the blast. It can be based on the immunophenotyping and immunohistochemistry, which is, as I said before, looking at those antigens on the cell surface and inside the cell. And it can be classified by the genetic mutations. Most classification systems use a combination of. Historically, there have been a variety of classification systems used for AML. One of the earliest ones was the FAB classification system. FAB stands for French, American, British classification system. It was exclusively based on the morphology and the staining of blasts, so how these blasts look. And you can see what the different subtypes of AML look like back then. This is really not being used much anymore because it doesn't take into account any of the genetic information that we now know is so important. We put it up on this slide because you still see it referred to in some patients' notes. It wasn't really helpful for giving us any prognosis for patients. So fast forward about 50 years, and you can see the latest iteration of the World Health Organization classification system, which is the one that is most widely used now. And there's been a number of iterations of this one over the years. And with each iteration, the morphology becomes less important and there's more of an emphasis on genetic parameters. So as you can see on this slide from the Munich Leukemia Laboratory, AML can be categorized in two broad ways, with defining genetic abnormalities or by cell differentiation. So if you look at AML defined by differentiation at the bottom of this slide, you can see that that looks very similar to the FAB classification. But if you look up in the middle with the defining genetic abnormalities, I think this is becoming more of the norm and more of the focus on classifying AML subtypes. This slide is just in to emphasize the fact that this classification system is ever evolving. So we're not going to go into any details here, but I think the importance is just to recognize that the genomic information is evolving pretty quickly. The techniques to determine the different gene changes is changing quickly. So we're going to continue seeing evolution of this classification system and new iterations. At this point, I just want to call out acute promyelocytic leukemia, or we know it as APL. This is a specific subtype of AML that is particularly aggressive. It's seen in about 10% of all AML cases. It tends to affect younger patients around the age of 40 years. It's associated with a coagulopathy that can be quite severe if it's not recognized early. These patients tend to bleed if their disease isn't recognized early and could hemorrhage to death. But if it's caught early and treatment is started, they have a very good prognosis and are often cured. The cytogenetic abnormality that's associated specifically with this subtype is translocation 1517. And what that involves is a fusion between the PML gene that's found on chromosome 15 to the RAR alpha gene, which is found on chromosome 17. This is a really useful marker when we're treating patients and following them after. Now, we're not going to go into any detail about the treatment for APL because it's quite unique compared to some of the other treatments. And we know that it was reviewed in the Leukemia 101 webcast that's available on the continuing education site. The WHO classification system is helpful for studying AML, but it really doesn't tell us a whole lot about prognosis. So there's been a risk stratification system that has been developed by the European Leukemia Network. This is the most recent version of it. It's really new, 2022. We've learned over the years that cytogenetics is the most important independent prognostic factor associated with AML and predictive of the overall survival of patients. So what the ELN group has done is looked at these genetic abnormalities and categorized them into 3 different risk groups. So you can see we have favorable risk. That means we think the disease is going to respond favorably to chemo for patients who have those particular genetic abnormalities. The intermediate risk group who we're not 100% sure how they will do. And then the adverse risk group who we know are going to respond very poorly to chemotherapy. And this information is really useful for determining treatment recommendations. And although we've said that cytogenetics is the most important factor, in actual fact, about 50% of patients will present without any cytogenetic abnormalities. They will have normal cytogenetics. And then the conundrum is, what do we do with this group of patients? So then we look for specific gene mutations. Up to this point, we've mostly discussed disease characteristics and those influences on prognosis and treatment. So now let's switch gears a little bit to talk about patient characteristics and how they impact prognosis and treatment. So we're going to talk about treatment shortly, but just to emphasize that curative intent treatment for AML is very intense and can be very difficult to tolerate. So we really want to know how fit the patient is to see if they can tolerate that. We want to know the patient's age. At one point in time, we used to say that any patient over the age of 60 wouldn't be offered aggressive treatment. We now recognize that chronological age should not be a consideration all on its own, and we treat people much older than that if their functional status and their comorbidities are not so bad. So we look at their performance status. Are they independent in their activities of daily living? We look at what kind of comorbidities they have to get a sense on what their organ functioning is. We want to know about their social supports because in treatment for AML is pretty intense. We want to make sure that they have caregiver support at home. As we said earlier, the older we get, the greater the chance of us developing AML. So there's a greater chance that we're going to have these comorbid conditions. We want to make sure the patient is cognitively prepared to deal with treatment. And also, we want to know what the patient wants to do. We want to know what their specific goals of care are. So we often categorize patients now into categories of fit, unfit, or frail to tolerate chemotherapy. We talked about the disease and the patient factors so far. So let's just talk briefly about the various chemotherapy agents that are used to treat AML. I like this slide. It's from Nature magazine in 2019 because it gives sort of a visual historical overview of the evolution of treatment recommendations since the 70s. So back in the 70s, the chemotherapy protocol known as 3 and 7, which is cytarabine along with an anthracycline, became the standard of care. So every patient who was diagnosed with any subtype of AML was given this particular. It was pretty good protocol because it got patients into a remission. The remission rate was about 60 to 80% for patients who are under the age of 60, and about 40 to 60% for patients over the age of 60. The challenge was keeping them in remission because the relapse rate was pretty low, with a long-term survival of only less than 30%. It was a very toxic treatment, but it's still being used today, and it was used for the next 40 years before we came up with other treatments. And these other treatments were really based on what we learned about the genetic basis for the pathophysiology of AML. And Shannon's going to talk about that when she talks about treatment. So patients don't have to have chemotherapy, and we often tell them these are probably their 5 different treatment options. And on this slide, you can see from least aggressive to most aggressive. So patients, we tell them we can just manage them with pain and symptom management without giving them any other type of treatment, with which they would probably only live a matter of a couple of weeks if we didn't give them any type of treatment or support other than pain and symptom management. Or we could offer them best supportive care with cytoreductive therapy. Best supportive care would involve transfusions. Shannon's going to talk about that shortly. There's non-intensive therapies, and then there's intensive therapies. If patients aren't interested in any of those or their disease relapse, we always have clinical trials, which are investigational studies. So just to sort of summarize before we start going into more detail about treatment, there's kind of 3 main considerations that we have to think about while we're coming up with a treatment plan. We have to know about the disease. Do they have favorable, unfavorable, or intermediate risk disease? Do they have any genetic mutations that may be amenable to new treatments? We want to know about the patient characteristics. How stable are they? What is their age? What is their comorbidities? How fit are they? And what do they want? Do they want curative intent treatment? Do they just want to prolong their survival? Or do they just want comfort measures? And then also the final consideration is what treatments are available. Those have been changing rapidly over the last 5 years, and what's available today may look a lot different than what we're going to see available.
Thank you, Cindy, for giving us a broad and very thorough overview of the diagnosis and prognostic approach to patients with AML. I'm just going to go through, hopefully, a bit of a summary around the current treatment approaches for acute leukemia. As certainly as Cindy has described, things have changed quite a bit since the 1970s. So this is a diagram that shows a little bit around the direction and how we think about patients and their treatment options when they're first diagnosed with AML, and how we can categorize into somebody who's fit for treatment with intensive therapy, or unfit for intensive therapy, and perhaps maybe is too frail to undergo any sort of therapy at all. So I'm going to go through that in a little bit more detail. So let's first talk about frontline intensive therapy. So as Cindy mentioned, in 1973 was kind of the introduction of that 7+3 regimen. This is the backbone of therapy and continues to be the backbone of therapy for AML. 7+3 is a regimen that consists of 3 days of daunorubicin, which is an anthracycline chemotherapy, in combination with an infusional 7-day cytarabine dose. And a study in 1981 showed a 71% response rate with this infusional ARSB. So this would typically be our standard induction therapy. Patients are admitted to hospital where they undergo the 7 days of chemotherapy, followed by 3 to 4 weeks of the recovery phase. And of course, cytopenias will worsen and complications are quite prevalent, including infectious or bleeding complications, thus necessitating an inpatient admission. Alternative protocols for induction include FLAG-IDA, and I know that there's various uses across Canada in this protocol. There was a study that was done in 2013 where FLAG-IDA was compared to 7+3. They found that there was a higher rate of death, but also a higher rate of complete remission, but similar overall survival. So I think the use of FLAG-IDA varies across the country. But essentially the goal of both of these induction protocols are to achieve a remission, wipe out all of the leukemia cells from the bone marrow, and restore normal hematopoiesis. At Princess Margaret, approximately 2/3 of our new AML patients receive standard induction with no hard age cutoffs. And of those who receive induction, 15 to 20% of those will be refractory, meaning they will not achieve a remission. And of those who do achieve a remission, approximately 50 to 60% will ultimately relapse. These are some newer additions to induction therapy that have come about, I'd say, in the last 3 to 5 years. Gemtuzumab, or we often refer to this as GO, is a conjugate of the monoclonal antibody, and it targets the CD33 antigen. So this is a drug that is used for newly diagnosed CD33 positive AML in combination with 7+3. It's most often only used in good or intermediate risk. We've also seen the introduction of CPX-351. This is basically the liposomal form of cytarabine and daunorubicin, and this is approved in Canada to be used for therapy-related AML or AML with myelodysplastic-related changes. We've also seen the introduction or the approval in Canada for the drug midostaurin. This is an oral agent that is used for patients who have the FLT3 mutation, and it's used in combination with the 7+3 regimen. So just to review that a little bit more in detail, the FLT3 mutation, the FLT3 is expressed in normal bone marrow cells and regulates the growth of blood cells, but it is the most commonly mutated gene in AML. There's 2 subtypes of the FLT3 mutation. There's the ITD or there's the TKD. We see the FLT3 ITD mutation in approximately 25% of all AML patients, and it certainly indicates a more poor prognosis. The FLT3 TKD is seen in approximately 7 to 10% of all AML patients, and at this point, the significance still remains a bit unclear. But if we can block this FLT3 signaling to induce apoptosis in cells expressing the mutant FLT3 and some other receptors, we can halt the growth of the leukemia. So some examples of FLT3 inhibitors are midostaurin, as I suggested, and gilteritinib. This is the ratified study that led to Health Canada approval for midostaurin to be given in combination with 7+3 during induction. Basically, this study was published in 2017. They had a group of 717 patients who were randomized to either standard induction and consolidation regimens with midostaurin or with placebo. And as you can see, the median overall survival that's highlighted at the top there was significantly longer in the midostaurin group. After induction chemotherapy is administered, we then need to assess the response to treatment. So a bone marrow aspirate and biopsy are often repeated. And this is a little chart to describe how we describe the response to treatment and whether somebody is in a complete remission. So to determine if somebody is in a CR, they have to have less than 5% bone marrow blasts and full recovery of their counts with a platelet count of greater than 100 or a neutrophil count of greater than 1.0. We often consider a complete remission with incomplete hematologic recovery, seen there on the line 2 as a CRI. And that just means that there's less than 5% blast, but there is some residual neutropenia or thrombocytopenia. We're now measuring minimal residual disease, which we refer to as MRD. And what this is the presence of leukemic cells below the threshold of detection when using conventional morphologic methods. So this is often done with flow cytometry. So we use morphology to assess the percentage of blasts in the bone marrow. And then we send a flow cytometry sample that can detect basically these, the presence of these leukemia cells that perhaps are there. If somebody has any presence of them, we consider that as MRD positivity. So if somebody achieves a remission, we move on to step 2, which is the post-remission consolidation therapy. Often consolidation chemotherapy is given anywhere from 2 to 4 cycles. The backbone of this therapy remains cytarabine-based. It has been studied in multiple areas across Canada and the US regarding the safety and feasibility in the outpatient setting. And this has been established, showing reduced costs and resources. With no difference in patient outcomes or safety. So some of the protocols include giving daunorubicin and high-dose cytarabine again. We also use a combination with gemtuzumab and with midostaurin as well. And we also do a FLAG-IDA consolidation. These patients do get the chemotherapy days 1 to 5 in the outpatient setting, and then are followed quite closely for 3 to 4 weeks after, usually 2 to 3 times a week for what we call a count check during their sort of recovery phase, where they'll need antimicrobials, transfusion support, and that type of thing when their blood counts remain low. So for those patients who can achieve a remission and perhaps receive 1 or 2 cycles of consolidation therapy, who might have intermediate or adverse risk disease characteristics, they may be referred on to have or be considered for an allogeneic stem cell transplant. I'm not going to touch on this in any detail at all, as we could do another couple of hours talking specifically about allogeneic stem cell transplant. However, many of our patients are referred, as the majority of AML patients do have these intermediate and adverse risk disease. So certainly the indications for transplant include whether the patient is eligible. They need to be fit to have a transplant. They need to have a donor available, whether that's a sibling or unrelated donor, and they need to be in a complete remission. So the only point I want to make here is that, you know, it is unwise to postpone transplantation given the outcome of relapsed AML remains poor. So, for example, patients do have a small chance of achieving a second CR after salvage chemotherapy. And we also know that there's inferior outcomes post-allogeneic stem cell transplant when somebody is in a complete remission for the second time. So usually we would try to identify whether somebody is fit and able to go on to allo stem cell transplant, you know, within the first month of diagnosis, you know, and hopefully the plan is to have induction, achieve a remission, maybe go on to have one consolidation, meet the transplant team, get worked up for the transplant and be admitted for the therapy. This is just a quick chart around, you know, should patients have a transplant? I'm not going to go into it in any great detail, but it is a very complicated decision-making process, depending on the patient's risk stratification of disease, whether they achieve a remission, and if they've achieved MRD remission, and their estimated risk of relapse. So not all patients with AML will require an allogeneic stem cell transplant, and not all patients requiring a stem cell transplant can receive them. You know, whether they might not have a donor, they may have comorbidities that preclude them for eligibility. So historically, we haven't really had any role for maintenance therapy in AML. We haven't had any sort of therapy. Usually these group of patients were just observed. But remember that 50 to 60% of patients will ultimately relapse. So we have a new therapy called oral azacitidine, which is the new standard of care. The study was published in 2020 called the Quasar AML 001 study, where 472 patients were randomized to oral azacitidine versus a placebo. Oral azacitidine is given 14 days out of a 28-day cycle. It's generally well tolerated, aside from some nausea, which you can see here affects up to 65% of patients. But it is generally a good option for patients because it can be given closer to home in the community. There's not a lot of travel required back and forth to hospital. So maybe a good option for that elderly group of patients who are not going on to transplant. And it is approved for use in Canada for those in complete remission, not eligible for transplant. This is the results of the study. You can see here that the median overall survival for those patients who received oral azacitidine was 24.7 months in comparison to 14.8 months with those on placebo, and that's a big difference of almost 10 months. So now we're going to talk about frontline, less intensive therapy. So these would be that group of patients who might be unfit for intensive therapy, but still want some therapy to control the disease. I'm going to take you back to the very beginning when we started using low-dose cytarabine in elderly AML patients. This study was published in 2007, and essentially it compared low-dose cytarabine, which is given 20 milligrams subcutaneously twice daily for 10 days, compared to hydroxyurea, which is an oral medication helped to break down the leukemia cells. So out of 217 patients on this study, all of which were unfit for intensive chemotherapy, 18% of the patients that were on low-dose cytarabine achieved a complete remission, whereas hydroxyurea, obviously you can see there only 1%. I think this study really showed us that achievement of a CR was strongly related to survival. So if you were able to get into a remission, your overall survival was much stronger. So this study was published in 2015, and I think really changed our practice in the management of AML, particularly in the elderly. This is the azacitidine trial. Basically, patients were randomized to receive azacitidine therapy versus the conventional care regimen, and the conventional care regimen could have been either best supportive care or low-dose cytarabine or intensive chemotherapy. And these patients were an elderly group of patients. And then you can see here that azacitidine was superior to the conventional care arm with 10.4 months in comparison to 6.5 months. So this became our standard of care for a long time for patients who were ineligible for intensive chemotherapy. Just to briefly summarize, we've got low-dose cytarabine, where the CR rate was much better than hydroxyurea, but overall survival remained poor. No patients with adverse cytogenetics achieved a CR. So this may be an option for patients who are elderly, not interested in intensive chemotherapy, but have favorable cytogenetics. This drug can often be given through home care. Patients have less trips back and forth to hospital. So, certainly this has been replaced by many other treatments, but still remains the backbone of therapy. Single agent azacitidine had a modest improvement in overall survival, 10 months versus 6.5 months, but a more recent population-based study that looked at this group of patients over 10 years showed a median overall survival of only 7 months. So I think it's quite variable. It does provide some benefit, but still not offering our patients a great option. So I want to introduce you to venetoclax. I'm sure most of you would have heard this before, heard of this medication. This is the new kid on the block. It is a small molecule BCL2 inhibitor, but to further explain that, the BCL2 protein tries to keep the cell alive with a lack of apoptosis. So if we can prevent the overexpression of BCL2, cells will move towards apoptosis and death. So venetoclax was originally used in the CLL population, and when initially studied in AML, it was seen to have poor efficacy as a single agent. But when you combine it with azacitidine for patients, we have seen some really good results. So the DiNardo study, which I'm going to show you in a moment, was published in 2020, where they compared, where they looked at venetoclax and azacitidine for elderly patients who were ineligible for intensive therapy. And this showed a median overall survival that was longer than reported in any other trial for frontline therapy in older AML patients. So this was the trial. You can see here it was a phase 3 multi-center trial. There were 431 patients that were randomized to receive their venetoclax and azacitidine versus azacitidine and placebo. And in the bottom left corner, you can see that overall survival in the ven-aza group was 14.7 months compared to only 9.6 months in the azacitidine arm. The bottom right chart is quite interesting, and I think something to really pay attention to is that by the initiation of cycle 2, 43% of patients had achieved a CR. And I think that's quite commonly seen in our practice as well. Patients do get good responses very quickly from this drug. I guess the unknown is for how long, and I think we're still studying that and how long patients can be on treatment for before they relapse. This is just a brief slide around the venetoclax AZA adverse effects. So as we know, with azacitidine therapy alone, we have, the old sort of common side effects of injection site reactions, mild nausea, and a bit of neutropenia and other cytopenias. When you add venetoclax to the azacitidine, we have seen much more or a larger degree of neutropenia and febrile neutropenic episodes. So these patients really do need to be monitored, particularly very closely during the first few weeks after starting therapy. I'm not going to go into any great detail about tumor lysis syndrome that was reported with venetoclax and azacitidine. However, I'm going to mention it briefly as it was first described when venetoclax was being used with the CLL population. We have not seen very much tumor lysis syndrome. In the studies, there was only 1% reported TLS, but it is something to know that when we're starting patients on treatment with this, we do like to provide some glucose reduction to get their white blood cell count down with probably below 25 before starting on the venetoclax. And they require daily blood work, looking at uric acid levels and phosphate and other electrolytes to make sure they aren't developing the TLS. So moving on to relapsed refractory options for therapy, a couple of key principles. Essentially, mutations such as the FLT3 mutation can appear at relapse when it wasn't originally detected, or it may also disappear, although this is less common. So approximately 20% of patients at relapse will have different molecular changes. So it's really important to repeat the bone marrow and send for molecular testing, as this may open up some options for treatments for patients that weren't there before. The other key principle is that patients with a complete remission that lasts less than 6 months are really unlikely to respond to a reinduction therapy. However, these options that I've put down below here are some of the things that may be presented to patients. So for those who chose the aggressive or sort of the intensive chemotherapy route, do they want to go on to a reinduction and then ultimately on to an allogeneic stem cell transplant? Are there more targeted therapies available for them? Do they want to try low-dose cytarabine or azacitidine plus or minus venetoclax? Are there any investigational studies at the leukemia centers that are available? Is best supportive care with oral hydroxyurea or palliative care at that point the best options? So just a couple of the targeted agents. I'm not going to go into them in any great detail, but I think that it's important for us to be really aware of them. Gilteritinib is another FLT3 inhibitor that is being used. It's not approved to be used in the first-line setting, but is approved in Canada to be used in the relapse refractory setting based on the Admiral phase 3 trial. The Admiral trial was published in 2019, where they compared gilteritinib, single agent, versus salvage chemotherapy. And so salvage chemotherapy could have meant high intensity, so a reinduction chemotherapy, versus a low intensity, such as an azacitidine or low-dose cytarabine. And the median overall survival was 9.3 months with the gilteritinib arm versus 5.6 months with salvage chemotherapy. And I just want to comment too that the overall survival benefit was seen in comparison to both the high and low intensity chemo groups. Enasidenib is a IDH2 mutation targetable agent. The IDH2 mutation is found in approximately 8 to 19% of all AML patients. Enasidenib monotherapy trial, it was a phase 1/2 trial, was published in 2018 in relapsed refractory AML patients. And basically the overall response was 38%, and a median overall survival of 8.8 months. Interestingly, approximately 40 to 43% of patients did achieve transfusion independence. So I think I've given you hopefully a broad overview of the treatment paradigm and how we sort of help patients make decisions about getting therapy. I'm not going to go into any more about the complications of disease and treatment, as that would be a whole other hour. But I think it's important to understand some of these complications, such as tumor lysis syndrome. The risk is greater with leukocytosis. Febrile neutropenia is very common in acute myeloid leukemia, which can include sepsis and admission to ICUs. A lot of opportunistic infections, in particular invasive fungal infections, central line infections, different pneumonias, lots of different skin infections are very common. Disseminated intravascular coagulation, or DIC, can happen in the setting of APL, as Cindy described earlier, but also in the setting of sepsis. So something to understand. We also see some differentiation syndrome, which can occur in particular with these IDH2 inhibitors. So something to be aware of too. Patients present with fevers and coughs, and it looks very much like sepsis, so important to differentiate between the two. QTc prolongation is a very common occurrence and something we really need our pharmacist colleagues to help with. There's a lot of drug-to-drug interactions. Certain medications, certain antibiotics, antidepressants can prolong the QTc interval. And in particular, I bring it up because our FLT3 inhibitors can prolong the QTc as well. And then transfusion reactions as well, something that we all need to be well versed on in managing things like transfusion-associated circulatory overload, hemolytic reactions, and be aware of very severe consequences of transfusion reactions like trolley. So thank you so much for joining us today. Cindy and I very much enjoyed putting this talk together. We hope you learned a little bit more about acute myeloid leukemia. Thank you so much to the Leukemia and Lymphoma Society for making this possible for us. Take care.
Thank you so much, Cindy and Shannon, for this very interesting presentation. I want to reiterate that you can use our continuing education program at your convenience. You can see on the screen here all the selections available to you. I would also like to mention that this event was made possible thanks to the support of AVI. If you'd like to learn more about AML, we invite you to listen to short training on our continuing education program, Case Study in AML, Optimizing Care in Patients Ineligible for Intensive Chemotherapy. And finally, I'd like to remind you that we are here for the blood cancer community. We can help those affected by blood cancer to cope with every step along their experience. You can order material to refer your patients and their family to our services easily. Thank you and stay safe.